Track 5. Today, we have an exciting lineup of speakers to share about their experiences as well as expertise. So first up, we will have Dr. Ho Vui Kia. He is an anesthesiologist and intensivist at Singapore General Hospital and Sengkang General Hospital, where he is also the head of intensive care medicine. His interests includes trauma, burns, resuscitation, and crisis resource management, disaster management, critical care rehabilitation, point-of-care ultrasonography, difficult airways, and medical simulation. So we will start off with a close encounter with COVID-19 and ICU patient's journey, and we are very pleased to have with us Mr. Raymond Koh, who will be sharing his experience in the ICU where he was inflicted with COVID-19 earlier this year. So we'll pass on to Dr. Ho as well as Mr. Koh.
You could unmute my mic. All right, Yi Lin, thank you for the introduction. And I want to thank the organizers for inviting me to have this opportunity to share with, and actually, and inviting Mr. Koh as well to share the experience of a patient in the ICU and what it is like to experience all the invasive lines and tubes, and also what happens after the ICU. I'm just going to share my screen now. Right, so this morning's topic is a close encounter with COVID-19 and ICU patient's journey. This is going to be, this is a very precious time. This is a very special time where we actually get to hear a first-hand experience from a patient. So it's going to be in a conversational style. And at the end of the session, we'll allow some question and answers. Yeah. But I just want to have some ground rules because Mr. Koh has taken some time to share his experience with us. I would like that we respect him and especially hold the highest regard for confidentiality. I will request that there be no recording, photographing, no screenshots, any kind of recording, basically, of any segments of this session, please. All right, please don't discuss this outside a hospital or clinical improvement context, and try to avoid any names. All right, so yeah, without further ado, I will introduce Mr. Koh. Mr. Koh ended up in our ICU sometime in early March when he contracted COVID-19, and he also shared his experience soon after he was discharged. And yeah, Mr. Koh.
Oh, hi. Yes.
Yep. Welcome, and once again, thank you for coming to share experience with us clinicians.
Pleasure.
Yeah, I want to know how it all started. I know sometime in March you received a diagnosis that you had COVID-19, and then your world just started to turn upside down. Can you tell us what happened?
Oh yes. Okay. Well, it started from 1st of March itself. I actually started to develop fever on Sunday, and the fever and after that, it's on Monday itself, the fever seems to be subside. So I went to the clinic and see, and the doctor says, okay, he's going to give me 2 days of medical leave just to see how is it. And apparently after 2 days later, the fever still come back. So I went back to the doctor, and after that, the doctor says, oh, okay, he's going to give me a few more days just to make sure that the fever is subsided. So on Thursday, when I go back to the doctor again, when he tested, the temperature was fine. So then he says it's probably recovering. Then by the time on Friday, the temperature went back to above the 37.8, 37.9, and it kept persisting going within that range itself. And on Sunday, I actually wanted to go back to the same clinic. It actually didn't happen because the clinic didn't open. So I went back to the sub branch of that clinic, and the doctor tested on my airways and checked on my lungs. It says that my breathing is fine, but it says to play safe, we'll send a ambulance down. So that's whereby they actually sent me to Sengkang Hospital. So along the way, when the paramedics was asking me, do I have sore throat? Do I have a cough? This was none of the symptoms that actually occurs to me that it was COVID, because it's just pure fever. So the only thing that comes into my mind itself was that, could I actually develop dengue, because persistent fever, something that that I understand was probably made due to dengue itself. But during that point of time, doctor says that the clinic doctor says that may not be that possible. So he actually the paramedic says that, okay, we'll go and check and see what is it. But they are not very convinced that it was COVID. That's why then they decided, okay, let's go to Sengkang Hospital for that as well. And I was put into this observation area whereby there are patients, probably two patients just beside me, but it's actually one bed away. So and after that itself, they actually scanned did the X-ray on my chest, and they find that something is wrong. It doesn't seem right, and that's whereby they started to put me to the isolation ward. And that was Monday morning. I was actually started to be in isolation ward.
When did you find out that you had COVID?
And after that itself, on Monday, they actually started to do a swab test. Early morning Monday, they started to do a swab test itself. So the swab came back. The first test came back itself. They says it was negative. That was more for the pneumonia and stuff like that. That's my understanding. And the second test came back and says that it was positive on Tuesday morning. One doctors came back to say that, you're tested positive on the COVID itself.
How did you feel when you received the news?
Okay, since the confirmation of my COVID, okay, I was totally lost. And the thing is, I can't believe that myself I can got it. Is that because I only travel to work and through and fro. I don't go anywhere else. That's one thing. Second thing is that I eat with my colleagues, and we are always at that one location, probably somewhere in Raffles Place, that hawker center, one area. So and I don't mix around with anyone else besides my colleague. So that's why I just don't believe it when they tell me that I actually got COVID itself. So my initial response to the doctor was that you what? I got COVID and it's positive. So and doctor says yes, it's tested positive itself. So that's whereby I start to have worry about my families, my friends, my colleagues, and the people that I met, over the past few weeks itself. Because I understand it was a 2 weeks incubation. The incubation is actually 2 weeks.
Yes.
And I think 2 weeks itself, besides my colleagues that I interact, well, because of my nature of my work itself, I do interact with other colleagues within the same building itself. And that's whereby, I start to worry. And then this thing keep constantly flashing in my mind itself, apart from where I get it from. And I do receive calls on that night itself from tracing team to ask me about what I do for the past 1 week and the past 2 weeks itself.
Okay. So you're a bit worried for your social circle, whether you have infected them. Can you tell me so from the diagnosis to the ICU, I think it was pretty fast. Can you tell me what happened at that stage and how were you feeling?
So on the same day, because the afternoon itself, doctors are coming to my ward itself to examine me and talk to me. So they the first doctor was saying that you look quite okay when you're talking. But however, later on when the other another doctor came in, and I think he's more specialized in lungs or some, he started looking at it and started telling me that, you know, I can feel your breathlessness when I talk to you. So I was like, I don't feel any breathlessness at all. You know, I still thought it's normal to me. But he did comment that, you know, if the condition worsened, I'll be warded to ICU. So the word ICU started to, you know, bring a very big alarm in my mind. Because my dad passed on during the ICU period. During he was in ICU, so that was something that that actually triggered the fear for me to go into ICU. Yeah, so the rest of things itself is still keep flashing about. You know, it's like, you know, who are the people that I need to remember that, you know, that I actually get in contact with.
Okay. You also, they were asking you for contact tracing at the time, lah.
Yes.
Okay. So you started to feel a bit fearful when when the doctors mentioned ICU, but and then obviously your oxygen, you needed more and more oxygen, and we decided that we had to bring you to ICU. What were your thoughts at that time when we were pushing you to ICU?
Okay. I think the first thing when I will go, when they told me that, you know, if my oxygen level would go, they will start to push me to ICU the following day. I actually was telling the doctor, you know, can I not go ICU? Okay, that's something that I really do not want to. So and the next day, and true enough, on that night is after the doctor saying that, you know, when he speak to me, I feel breathless. My oxygen level actually went down, and the next day when I was next morning is I think kind of about 9+10 late morning, they start to push me into ICU. The first thing that I thought into my mind is like, you know, would I be like my dad, that, you know, that actually inside the ICU? Because when he passed on during the point of time itself, we didn't know, because the air was actually pumping into the lungs, and then we didn't know that he's still breathing or not. Because from the point, I can still see his stomach, you know, going up and down. So I thought he's still breathing. And only later stages, then we realized that, actually he has already passed on. So I am having that fear that, you know, am I going in through the same process? And when I go into ICU, it was like, you know, a different kind of room from what I see that I used to see on the ICU. But this is a true full glass door ICU room itself, and double layers for the staff to wear their protective gear. So doctors start to tell me about the intubation process that is supposed to go to my throat, that large tube of thing that's supposed to go into my throat. And then
Yes.
that triggers my wild thoughts and worst scenario thought that, you know, I may not go out of the ICU itself, because that is the same scenario that I saw on my father, having the throat inside itself, and then, you know, and that's whereby, you know, I was thinking, should, you know, I may not come out of ICU, I may not go out of ICU because of this. So after that itself, the next thing that happens, you know, is they put on some something that asked me to breathe, and then asked me to count 1 to 10, and after that I was totally unconscious.
Okay, so just a lot of fear just before you became unconscious.
Yes. Yeah, and because doctor told me about the tube is that tube has the imaginary tube has been stuck in with me on my mind for, you know, for the longest period of time, you know. So even before I go unconscious, I'm still imagining that tube.
When did you first gain consciousness again? Yeah, and you started realizing, I have all these things in me. And what was
okay.
like?
It was because following day it was Thursday. So Thursday morning, I woke up. So of course, the first thing is when I woke up was a nurse who actually woke me up and actually greeted me, very warmly. They says, "Good morning, Mr. Koh." So it's something that actually warms my heart when somebody greets you "Good morning" warmly, and then it just I feel suddenly like, okay, I'm a little bit more calm. Okay, and then after that itself, I can see that my hands are tight. I cannot move my hands. I cannot talk, and I realized that something is actually already, the tube is already in my throat.
Yep.
And that's where the part. But because probably before that, I already know that the doctor says that you're going to do this, the tube is going to be in the throat. So I didn't actually start to panic and then when I asked the nurse itself why was the hands that I cannot move my hands and things like that itself by doing the actions, and then the nurse says, "Oh, this is to prevent you from panic and pulling out the tube." So I realized, oh, okay, this is what they are doing itself, because say, okay, fine, I will not that I will just lie down there, but I want to ask certain questions, but I can't ask, so I actually asked the nurse to give me a pen, then I can write on the paper. Then they will know, okay, what I actually want. But through this communication to the nurses itself. And after that, when I was given this foot massager, something that on my feet itself to massage my feet. So my whole body, I was looking at it, so I got tube and on my throat, and I didn't know there was one in the nose until in the later stage, and then there was one on the neck, and after that itself there are two on my left arms itself for the bloods, and so but the whole thing, after when I wake up itself, with even though with all the greetings and all thing, I feel slightly calmer, but the images of me not getting out of ICU alive is still flashing, because the fact that I cannot move, the fact that the whole tube is still inside my throat itself, vividly let me think about the same image that I have it on my dad. Yeah,
that sounds quite terrifying, actually, especially when you have a prior experience by proxy with your close family member.
yes, it does.
Would you say that the communication, like before we put in the tubes and even after that, did it help you to like understand that, okay, these things are necessary, and help you to pull through your time in ICU?
It actually calms me in terms of that the process is necessary. By prior beforehand, they told me that you need to go through put in this and this is so I understand the logic behind it, and that's why when the tube was there itself, they I wasn't panicked to have the tube on that the tube was inside, because probably before that they already told me about it.
Okay, can I ask what you've already mentioned a few terrifying things, but what would be the most terrifying thing that happened to you in ICU?
Okay, I think because because of the tube and plus my hands being tied, that I can't move. So what happened? The images of not getting out is already one of the very terrifying thing that I actually have it itself. And because on that particular day night, starting from 10 p.m., I start to have my lungs seem to the whole thing like collapsing, that kind of feeling. And the whole body doesn't seem to be functioning, because I can feel the numbness and the pain and also achings almost everywhere as well. And the heart seems to be slowing down. So, and I cannot sleep, and I cannot sleep, and I cannot call people, I cannot talk, or all these things as well. Though I haven't, I can see that the nurse is constantly watching me, but it seems to, it's just to make sure that no, I'm okay, the vital signs are fine. It seems to me there's no other alarms or anything from the devices that's actually monitoring itself. But my whole body and is going like no, it doesn't seem right. And everything is painful and things like that. I can't talk as well. And because I can't sleep, I thought that I can just sleep and then to get through with it, but I can't sleep. I keep watching the clock, and starting from 11 p.m. and when I close my eyes and then and I thought I slept long enough. Then I open my eyes itself, it's only 15 minutes. So that period of time itself is like every minute to be every time I thought I slept almost 1-2 hours, it becomes only like a very short time of 15 minutes itself. At that point of time, images of my families, images of my friends, my social circles people as well, coming up to in front of me, and I do not know whether if they are being infected, and what if they are infected itself, then who's going to I can't be and if I were to go on, the first thing suffering will still be my family itself. And then those who actually got infected, what's going to happen to them? And if they were to get infected, their families will be infected. So the repercussion looks very big itself. And that's through the mind itself. I was like, wow, what is going to happen to them? And because the contact of me with so many people as well, so the worry is still there. So the guilt of if people were to infect it and infect somebody itself, and if the person recover, it's fine. But if the person does not recover, then it doesn't. Then the guilt will be carried with me itself forever on my mind itself. That's the whole thing, and this whole process took like forever, thinking.
Well, sounds like it's a really heavy burden, and you can't even walk away or distract yourself. It seems like you were suffering in constant pain, but no way to tell people. Do you still? Many ICU patients actually have experienced flashbacks or nightmares after they leave ICU. Do you still have these? Do you experience any of these at all?
The experience for this nightmares, going back to ICU, the fear has been there for since after I came out of ICU and recovered from COVID itself. But whenever people talk about ICU, the images will start come out. That how I was being with my throat and everything, the tube inside and things like that, and the whole room with the glass door, and the image is very clear, very vivid, and the fear is still there. I've been through some processes of trying to remove away that pain. Well, it does help a little on that, but the image will always be there as well. So occasionally when people talk about ICU, I was like, oh, I'll first one will start thinking about the rooms, the tubes, anything that is actually coming into my my body itself. That's the fear that is the phobia that I will still have. I think it probably will carry me for a long while.
You've gone through a lot. What would you say was the thing that helped you the most to help you the most to try to bring you through your time in ICU?
I think apart from all these images that I have itself, so the one thing that I feel that that pull me through most of the time itself is actually the greetings from the nurse, the encouragement from the nurse itself. I have not seen in most of the wards itself as in normal wards itself, but in ICU itself quite differently that every morning the nurse will greet me, and when the nurse greeted me itself, right, it's always very vibrant, very happy, the kind of greeting itself. And when they greet, and they always give encouragement to say, Mr. Koh, make sure you get well fast, and then after that, you can go out and see your family. So it's a constant affirmation from them that actually lets me be able to know, yes, I need to see my family, and yes, I want to get out of this place as soon as possible itself.
So we are running out a little bit of time, but so we're going to move a little bit on to the recovery phase. Understand that you started to get out of your bed and started to walk pretty much soon after we got the breathing tube out, and you got your breathing tube out after about 5 or 6 days in ICU.
Yes.
I'm just wondering, physically, are there any problems doing things? Even has there been any hindrance in even getting back to work?
After the ICU itself, I was actually doing work from home for the past 4 months, though I started to work in April, and after which itself, I will only be doing things as more into admins. When I actually started really to work in the office itself, at home it was still fine. The only thing is because we don't wear masks at home. But once you start into office itself, yes, the breathlessness will still be there occasionally. And with the mask on itself, is even more frequent in terms of the breathlessness itself. I tried to do running previously, but it doesn't really work because after running for just a short while itself, I start to catch my breath. It was quite hard breathing. That's what I actually had itself. And the other thing itself is that mentally, I feel that a lot of things that I will try to remember, it doesn't seem to register quite fast nowadays. When I do certain things itself, learn certain things, the learning process itself seems to be even a little bit more longer, to pick up. Apart from, I'm 40 plus, but I don't think that is the main thing, because certain things I really learned in February, but when it comes to back again to ask me to do the same thing, which I've been done for past few months prior before my COVID, it's like quite a missing sector here and there itself. So it's not a full picture of the whole process. So this is something I also discover itself. That apart from that itself, right, occasional the breathing, breathlessness, also can feel that the heart will have aching on and off. When I start to have breathlessness, I probably will have this heart aching feeling. Yeah.
Okay, I think we have to wrap up. But Mr. Koh, I just want to ask you, what message or one or two points would you have for healthcare professionals looking after patients like you in the ICU?
I think the very important thing is that the aftermath of ICU, like, actually makes me have a very different view, okay, on ICU. It's like, my previous assumption on ICU was that, when the person is critically ill, he will probably be put there and may not come out alive, or probably for a long time itself. But because it's just monitored by machine itself, but I was wrong on that itself. The staff is actually is also constantly monitoring and giving patients mental support and encouragement, which I think is a very key factor for a faster recovery. And that's something that also helps me to do a faster recovery on during the period of time when I was actually having COVID ICU.
Okay, thank you very much for sharing your very personal experience and your revealing your fears, sometimes even your guilt. And thank you. It's really enriching for us to see what we cannot see, because patients cannot talk with the tube in. And thank you for sharing that. It's really enriching for us.
Thank you for giving me a chance to share.
Thank you very much, Mr. Koh and Dr. Ho. I think we've got one question from the audience. Perhaps, Mr. Koh, you could help us to answer it. The question is, how could it have been better? How could we make life better for an ICU patient who is intubated with the tube in the mouth, with their hands tied, and who are not able to express themselves? How do you think we can actually improve the experience from our patients for this?
For my case itself, because I actually requested for a pen and a paper itself to communicate to the staff. Because initially they wanted me to write on the bed itself, using a finger. But apparently, whenever I write itself, right, it takes some time for them to register to understand what I'm trying to say. So in the end, I asked for a pen and a paper, so they will give me a pen and paper to write. I think the second thing itself is that once the patient is comfortable, the tying of hands, maybe it can actually loosen slightly a bit, so that the patients can feel that, let's say for the two hands to be together. I think that makes them more comfortable, makes them more secure in terms of for their heart as well. They probably will feel slightly better if we were to let them able to have that. That's provided they are calm and they know that the tube is actually inside. Yeah. I think these are something that I thought. The other thing, of course, will be if you have a pad that you can actually let them type. That will also be an idea as well.
Okay, definitely. I think these are worthy points for us to explore subsequently. Again, thank you very much for your time, for taking time out to come by to share with us your very personal experience with COVID-19 as well as the ICU. I'm sure that together with us as well as the entire audience, we have learned a lot from the patient's perspective because these are often sites that we are unable to see when we treat patients clinically. And then, so thank you again, both you and Dr. Ho. And then we'll move on to the next two speakers who will hopefully help to be able to address some of these concerns that you've experienced and how we can actually improve ICU survivors' outcomes subsequently, both in terms of rehabilitation as well in form of nutrition and to help and bring patients back to their usual form. So the next up, we'll have Dr. Charles Lew, who will be talking about making victors out of ICU survivors, the nutrition journey. Dr. Charles Lew is a principal dietitian from Ng Teng Fong General Hospital who specializes in critical care nutrition support. He completed his PhD at Flinders University and has published a number of papers related to his thesis. Charles' interests includes nutritional assessment and nutritional support in the critically ill. He's the co-chair of the Allied Health Research Panel at Ng Teng Fong General Hospital and the treasurer of the Society of Parenteral and Enteral Nutrition Singapore. He will also be an associate faculty of the Singapore Institute of Technology's bachelor degree program for dietetics and nutrition. So let's welcome Dr. Charles Lew.
Hello, just let me share my slide. Can you see my slides?
Yes, we can.
Okay. Okay. Thank you for the invitation, and thank you, Mr. Koh, for actually sharing very valuable information, because I never knew that my greetings sometimes in the morning and my nurses has actually significant impact, and that thing I really will remember. So I have a strong passion in nutrition support, and I would like to just talk about how can we create jobs. So for example, like Mr. Koh has said, ICU, how can we make them because and be functional again. But before I talk about ICU, I want to quickly summarize what we know about nutrition support in ICU, and we aim to create survivors. Now, Zenton recently published an idea of ICU is during the acute physical illness. We don't want patients to have a very central to do and gradually increase the amount of calories and protein provided to the patient. On this, can get them the requirement to provide 100% of what it makes sense because in recent cohort 2, we can see of patients actually increase with time. And this repeated by a COVID-19 study where we can see the energy expenditure increase with time. So there's really no rush to provide the energy during the acute phase, the early phase of the illness. This slide shows several reasons in the impact trial where we can see a patient with ARDS who immediately receive more calories initially, but they don't need so much and less later. Tends to be the people
Dr.
who...
Lew, sorry to
Yes?
just cut you. I think that the reception is breaking up. Maybe you could just speak closer to the mic or something.
Oh, all right.
Yeah.
Is it better now?
Yes.
Okay, I'll try to speak slower too.
Okay.
So we know that patients who have ARDS who receive more calories and then less later tends to be the non-survivors, and patients who receive lesser calories and more later are the survivors. Now the beauty of science is repeatability. These observations repeated in my study in Anti-inflammatory, where we can see that patients receive lesser calories initially and more later are the survivors. Now, this makes a lot of physiological sense because during the acute phase of critical illness, nutrition cannot be metabolized well because of mitochondrial dysfunction, as discussed by Nathan, and also previously by Eva, the trial, showed that patients receiving more calories initially tends to produce a lot of free radicals that can damage cells. When we provide calories and protein, we also would want to attenuate catabolism. But again, we know that we find the ID shown and what amount of protein or glucose given will be able to attenuate catabolism. Lastly, when we give protein and calories, we want to encourage catabolism, and we know that this is not good. Now, we can see that this is not possible because at day 1, but the presentation where patients are given food, the amount of protein on day 7, when the same amount of calories and protein is given, the patients were able to produce muscle. So this tells us that there's a time and season for everything. We can always delay so what and where be victors.
Dr. Liu, so sorry to interrupt you again, but I
Sorry.
think you're breaking up again. Do you
Okay.
think we could try to maybe unplug and replug your mic?
Okay, sure. Is this better?
Yeah, I think you can continue. We'll let you know again if there are issues.
Okay, I'm so sorry. Okay, so when the patient is in the post-ICU phase, we would encourage higher energy and protein intake, and also higher calories once they are discharged from the hospital. To provide 5 kilocalories of protein is really hard, which demonstrate patients post-ICU intake. Now, this actually has been shown very well in a recent study by Nakamura, which is, I think, it's just 2 months ago. But in this study, the principles encourage autophagy, gradual increment energy, and protein is executed. This overeating is reduced by giving only 20 kilocalories body weight, and also for the they included exercise when providing nutrition, and also post-ICU discharge patients where patients are really in anabolic phase, more protein is given, 20 grams of whey protein is given. Now, this is a quick summary of what was done on day 2. Patients are really patients 20 meals per hour, and then it's over high protein feed, the other group received normal protein feed, and if all this cannot be achieved, supplemental parenteral nutrition was given. In one of the arms, they received electromuscular stimulation and mobilizing. So there are basically two arms, one that received high protein and one that received low protein. Everything else, say, protein activation, is the same, with also one of the arms receiving muscular stimulation. What was found is the femoral muscle volume loss in the subjects receive high protein to be much lesser, and this is statistically significant. When there is a subgroup analysis, we know that the patients that receive electric muscle stimulation use loss. So now we have patients where they need more calories and protein. But again, we know that studies consistently show that not enough. Let's look at the first week of patient, ICU patients. In the really good study, Peterson has demonstrated 50 patients that patients are only receiving about 50% of their calorie requirements in the first week of ICU discharge, and only about 30% of their protein requirement. In a more recent study, 28 subjects were recruited. When the NGT was left into the patients survive the environment, but if their patients are left to eat on their own, only receiving about 50 to 60% of the requirements. And just within 5 days, we already detected significant muscle loss at the quadricep muscles and location within 5 days. But we can do that the second to the 4 weeks. But so far we have studies until 4 weeks. So in this study, which is days, we can see that patients who are left to eat are only receiving 55% of requirements, as opposed to the green line where patients where the tube is left in, patients are receiving 100% of their requirements. And why are these patients not eating? It's because they have poor appetite, early satiety, taste changes, and also things like swallowing difficulty and dry mouth. What about 3 weeks? Maybe in 3 weeks they'll get better. That's not true again. Leanne Chapter has actually shown that in the NICU, patients are again eating only about 50% of lunch. And I want to share Charles Lew, which is the 4-week observation by Emma Ridley. If patients are left to eat on their own, they are only receiving about 40 to 50% of the protein and energy requirements. But if you were to let the patient eat, drink whatever supplements that they can drink, and all the calories that are eaten.
Dr. Lew, I'm really very sorry to interrupt you again, but I think that we are having a lot of problems hearing you clearly from our side. And I think, do you think it's possible to move if there's another laptop or computer away from you, or perhaps you could speak directly into the laptop itself? Not sure if that will actually help to reduce this static and interference that we are experiencing.
Okay, let me try again. Is this better now?
It breaks up intermittently, so it's a bit difficult to tell. Yeah.
Okay. Not sure why, but I will try to again speak slowly, I guess. You just let me know if I'm breaking up again. Is it all right? Okay. So we know that even for up to 4 weeks, if patients were to be left on their own to eat, right, they are only receiving about 40 to 30% of their requirements. So why are patients not eating? Because patients post-ICU?
It's still breaking up. Do you think you could try and unplug your headphones and speak directly into the computer?
Is it better now?
Speak louder.
Can you hear me?
Yes.
Okay. The reason why patients are not eating is because of the derangement in the appetite controlling hormones, and also they have higher levels of nausea and satiety, and also they are not as hungry as healthy subjects. Oral intake. There is also this perception by clinicians that is contrary to recovery. I have already demonstrated that if we were to leave patients to eat on their own, they are only receiving about 40 to 50% of the requirements. But if we were to leave the tube in, allow the patient to eat whatever amount they would like to, we will be able to meet 100% of their requirements. So my suggestion is not to remove the tube feeding, the entry tube, until oral intake is established. This is what we call tough love in the ICU. The next thing is, once the patient is discharged from the ICU in the general ward, we know that treating the malnutrition in the general ward reduces mortality. This is well demonstrated by Philip in the EFFORT trial, where 2,000 patients were given customized nutrition support, where initially they are given food fortification and snacks, and within 5 days, if they are not receiving the amount of calories and protein they require, they'll be given enteral nutrition, and within 5 days, again, if they are not meeting goals, they'll be given parenteral nutrition. Now, in this study, it was shown that there is a reduction in mortality, about 35% hazard risk, and also, and this is statistically significant. Unfortunately, when the study is, when we observed the patient at 6 months, there wasn't any mortality difference, and there wasn't any differences in hospital readmission and falls. This clearly shows that nutrition support works in the hospital, but once they stop nutrition support, there wasn't any effect. And this is highlighted in the Norris trial, where 600 patients were recruited. One arm received high energy, high protein supplements, and the other arm received a supplement that's like juice. We can see that there is mortality reduction of up to 50% in patients who receive the high protein, high energy supplement, and patients also gradually gain weight over 90 days. The difference between this study and the previous study is this study, patients at discharge are still given the supplements to drink twice a day. And we know that by doing that, there is mortality reduction. And also in a very recent trial, not only mortality was reduced, patients will also have higher hand grip strength. So strength was also increased in the subgroup analysis. So can we do more? Definitely. Apart from leaving the tube in and getting patient to drink, we can do more, especially in patients with poor appetite and early satiety. And we can use nutraceuticals like leucine, HMB, omega-3, and multivitamins. I'll explain a bit in a while. Now, patients, we know that ICU survivors do not eat enough because of poor appetite and satiety. We also know that at each meal, a patient requires about 0.4 grams of protein per kg at each meal to maximize their muscle protein synthesis. So take for example of a 60 kg patient, this will mean that he or she will need to consume 1 palm size of chicken, beef, or pork at each meal for 3 times a day. In my clinical experience, this is near to impossible because of the poor appetite and early satiety. So this is where leucine can be used, because leucine is one of the most anabolic amino acids that works on the mTOR pathway, which is important for protein synthesis. It can be added to lower doses of protein to achieve similar rate of muscle protein synthesis. as shown in this. So patients who are at risk, one group receiving low protein, the other receiving high protein. In the low protein group, if they were to receive 5 grams of leucine on top of the low protein, the amount of protein synthesis is exactly the same as the patient who is on a high protein diet. When they're exercising, if the low protein group would receive leucine, they again receive have the same muscle effect for patients who is taking high amount of protein. So which means if leucine is given, they do not need to eat as much, which is only half the, in effect, they're only eating half the amount. So these will be taken with leucine and capsules or powder. The problem with leucine is leucine usually comes in 500 milligrams, and that would mean 10 capsules at each meal, 30 a day, or 3 tablespoons of bitter tasting substances added to food. So if this cannot be done, then we can use nutritional supplements that is high in energy and protein to make the patients in the high protein group. And these are some examples of high protein, high energy nutritional supplements. Another very interesting compound is HMB, which is actually a metabolite of leucine. 5% of leucine is converted to HMB in the body. It works on the mTOR pathway, but HMB also works on the IGF-1 expression. And more importantly, it has similar anabolic effect as compared to leucine. But the age where HMB comes in is it's also anticatabolic, because leucine is anabolic, whereas HMB is both anabolic and anticatabolic by the ubiquitin-dependent protein proteolysis pathway. It blocks this pathway. So what is the clinical evidence of HMB? We know in a systematic review of 15 RCTs performed on hospitalized patients, HMB increases skeletal muscle mass and also strength, although small effect. But these are in non-critically ill patient. In critically ill patient, there's only one study thus far, and that is by Nakamura. We can see that patients with a SOFA score of less than 10 respond to HMB feeding by a reduction in the muscle loss. It doesn't happen in the patient with high SOFA, and is very likely due to high inflammation and high disease severity in this patient. The effective dose is about 1.5 grams twice a day. It can be given by powder, 1 capsule 3 times a day, which is usually, because comes in 1,000 milligrams per capsule, or a patient can drink this product. There's only one in the market by Abbott, twice a day, and they can also meet their HMB requirements. Now, the next thing I want to talk about is inflammation, because in the EFFORT trial, we know that inflammation may reduce the mortality benefits of nutrition support. Because in patients with CRP less than 100, we can see that nutrition support was able to reduce the mortality, whereas in patients who has high inflammation, nutrition support wasn't able to do so. And this was again exhibited just now in this study, where we can so far more than 10 is a surrogate marker for inflammation. So what we can do, we do not have direct study in the ICU, but we do know that omega-3 has a role in sarcopenia, because it can positively, is associated with muscle mass, strength, and quality, because omega-3 also helps reduce inflammation, enhance mTOR signaling, and also reduce insulin resistance. In the EFFORT trial, most patients are also given multivit. This is just a very busy slide showing that in the mitochondria, vitamins and minerals are used in multiple steps as coenzymes in the mitochondria. So it is then, it just makes sense to just let them pop a pill in the presence of them not eating enough. So more research needs to be done. Now, what I have mentioned is all about generalization, what we know in research, but we cannot cookie cut every patient because they are all different. Therefore, we should look out for biomarkers, which is very trendy now, but we do not know which one to use as of now, but these are new research that needs to be done. And one thing I need to highlight is nutrition trials are generally disappointing in the ICU arena. And I suggest it could be because there are subgroup of ICU patients that may respond differently to nutrition therapy, and hence the overall effect is being diluted. So it's very important for us to identify the phenotype that will respond differently to nutrition therapy. And this can be done by, if you were to identify effect modifiers to nutrition therapy, like the disease type and severity, who are the patients who respond better to nutrition therapy? Will the nutritional status post-ICU discharge affect their the impact of nutrition therapy? And also any perpetuating factor like I just mentioned, persistent inflammation. We again need to know the energy and protein type, dosage, timing, and delivery post-ICU discharge. And if we were to use nutraceuticals, again, the dosage, the type, and the timing. And environmental factors like socioeconomic factors, psychosocial factors, and rehabilitation are also all important in helping the patient be victors. ICU staffing and the amount of equipment and culture. For example, if there's this culture of removing the tube prematurely, and that's not ideal. And also, if we were to use nutraceuticals, then we need to think about their safety considerations. So what can we do for now? Number one, we know that we can gradually increase energy and protein in the ICU. We will encourage early mobilization and exercise. Post-extubation, try not to remove the tube until the patient demonstrate that he or she is eating enough. And we perform nutrition assessment to prioritize the real malnourished one. And if when they're in the general ward, continue to provide intensive nutrition support. And also that would mean that if patients have poor oral intake, we can use oral nutrition support or nutraceuticals. And more importantly, continue nutrition support post-hospitalization and getting them back to outpatient to see the dietitian to ensure that they are eating enough. With this, I thank you for your attention.
Thank you, Dr. Lew, for the excellent talk. We've got some questions from the attendees over here. So the first one that we have that is, could post-extubation dysphagia contribute to the low oral intake? If so, in your experience, up to how many days or weeks post-ICU discharge can we expect this?
This is really variable. Some patients can go back on oral feeding within a week. Speech therapy is on board. Some with patients tend to don't do well when they are intubated for a prolonged period, where they have muscle wasting, and they are the ones that are at higher risk. So it's quite variable. And because of this variability, premature removing of the tube may not be optimal. Leave the tube in, but more importantly, let the patient has comfort feeding, let them eat whatever they want, and also let them drink any nutritional supplements which they need. Because eating itself and drinking is a pleasurable and normal experience for patients.
Okay. Another question we have from the audience is, they mentioned that one issue with the Nakamura study was the different source of protein in the experimental versus the control group. Any comments?
Yes, definitely. In the Nakamura group study, one of the group received peptide, which is peptide, and the other group received intact protein. Now, it does make sense that this is not a really fair trial, but we also know from other studies that there isn't strong evidence to show that peptide will perform better in as compared to intact protein. But what we can more importantly get from this study is peptide feeds are better absorbed and patients can tolerate better. And more importantly, higher protein delivery will have a significant impact on patients' muscle loss, a positive effect on that.
Are there any other questions from the audience? If there are, please type in your questions into the Q&A tab and we will answer them. Perhaps I can ask a question. So often in the ICU, especially in patients with COVID-19, these patients often require high doses of sedation, paralysis, sometimes even prone positioning for this group of patients. How do you think we should modify their nutritional intake depending on what form of interventions are being utilized?
Yes, when high inotropes are used or when patients are prone to have high gastric residual volume, so in this patient, I tend to use feeds and feed them at low rate. One important thing to remember is because these patients are in a very acute phase, the patient do not need that much calories. So using a peptide feeds and running at a lower rate will enhance tolerance, and that is what I have observed clinically.
Okay, sure. Okay, if there are no further questions, we'd like to thank you very much for your time. And then we'll move on to Miss Audrey Lee, who will also touch on and elaborate more about your conclusion slide where you spoke about the importance of physiotherapy, early mobilization, and perhaps Audrey can actually provide further insight into this topic. So next up, we have Miss Audrey Lee, who will talk about physiotherapy and our battle against COVID-19. The experience from the National Centre of Infectious Diseases Singapore. So Miss Audrey is a senior physiotherapist currently working in critical care. She has 6.5 years of clinical experience with interest in respiratory physiotherapy management for patients with respiratory diseases and in critical care. Audrey has contributed significantly to the early mobilization of critically ill patients in the medical intensive care unit. She is also involved in the development of an on-call physiotherapy service for patients who require urgent physiotherapy review. Beyond clinical practice, she actively seeks opportunity for the development of physiotherapy management in the critical care setting. She is currently the leading physiotherapist at the National Centre for Infectious Diseases, NCID, in the current pandemic. And her latest research is a case series on physiotherapy interventions in COVID-19 patients. We welcome Ms. Audrey Lee.
Hello, thank you for a kind introduction, Dr. Lee. Let me just share my screen. Okay, can all of you can hear me?
Yes.
Okay. So the agenda for today's presentation basically is to describe the challenges in the management of critically ill patients with COVID-19 and to also describe the unique clinical presentation of Plectinia autodeoxia syndrome in patients with COVID-19 at NCID itself. From this presentation, I will also be discussing the consideration and strategies used in the rehabilitation of critically ill patients with COVID-19 in a various settings, starting from the ICU all the way to the community. So let's start with rehabilitation in the ICU. Those who are working in critical care will be quite familiar with early mobilization itself. From non-COVID patients, we know that the early mobilization actually can help to improve muscle strength at ICU discharge, improve walking ability at hospital discharge, and even reduce participation restriction at 6 months follow-up. However, due to the infection control status of these patients, especially during the very acute stage of the disease itself, the equipment that we usually use, such as the hoist, shown on the left, and motomat on the right, to get patients to participate in rehabilitation are actually restricted and they cannot be easily used in our ICU setting itself. Another challenge that we had during COVID outbreak was knowing that during mobilization, we observed that some patients at our center actually have significant desaturation, especially when we get them to sit upright. So in an unusual clinical scenario, such as early mobilization, we would then titrate the ventilator settings and provide oxygen therapy. And this would usually resolve this desaturation. However, this was not the case for patients with COVID-19 itself. So actually at our center, one of our doctors actually published a recent paper by Dr. Tan. He actually presented quite a number of patients that had this syndrome known as Plectinia autodeoxia syndrome, where patients, once they are in upright, they will have significant desaturation. So what does this actually mean for us as physiotherapists is that we cannot actually do the early mobilization that we are actually quite familiar with. Patients are unable to tolerate sitting at all. We also cannot do early mobilization such as sitting out of bed and even ambulation. The exact pathophysiology of this clinical syndrome is still unclear, but it was hypothesized that POS is actually due to a gravitational exacerbation of intrapulmonary shunt in ARDS due to severe COVID-19 and is related to vasculopathy and increased wasted ventilation. So for physiotherapy management wise, we will have to change how we usually carry out our physiotherapy session. So this will include continuous monitoring of vital signs during physiotherapy sessions to identify and detect any significant desaturation during our session. We also have to change our exercise strategies, such as use of interval exercise training, and to use a stepwise approach for early mobilization. So in the ICU setting, there are usually vital signs monitoring for all patients. So during our session, we would then ensure that we keep a lookout for desaturation, especially if we were to move these patients to upright position. So if significant desaturation were observed, despite titration of oxygen therapy or ventilator settings, we would then return these patients to supine position to rest with supplementary oxygen, and we will do most of the rehabilitation in a supine positioning where we know that the patient's oxygen saturation will be fine. So for rehabilitation itself, we will also use the interval approach as mentioned by giving them multiple rest breaks, especially during the initial phases, as they are unable to tolerate continuous training. And there's previous evidence from other group of patients which shows that actually interval training can delay onset of lactate acidosis and reduce ventilatory requirement. It also decreased the symptoms and sensation of dyspnea and increased exercise tolerability. And both interval and continuous training have equal improvements for functional outcomes. So what we are trying to do here while the patient's lung continue to recover from COVID-19 is to then preserve their muscle strength and try to preserve their muscle bulk so that when the lung pathology actually resolves, they are actually back on their feet as soon as they can. For early mobilization, we then have to adapt a different way of mobilizing them. So instead of getting them out of bed, we would then do things like progressive verticalization by getting them into a more upright position. So if they can tolerate a chair mode, we would then put them in a chair mode, then before moving them to sitting over the edge of bed and then out of bed. And with that, we are also looking at gradually increasing the duration of being in the upright position. So for patients who are unable to tolerate even with the bed propped up, we will then supplement with a lot of bed exercises. They can be active assisted or active exercises shown in this picture where the therapist is actually assisting the patient. We can also use things like TheraBand, which is single patient use, and even modified loads such as use of light weights for patients to help them to preserve their muscle strength until the lung gets better. We'll now move on to rehabilitation after the ICU itself. I think Mr. Koh has shared quite extensively on some of the cognitive and psychological impact for patients. For my presentation, I won't be touching much on that. In our institution itself, the cognitive and psychological aspect of ICU syndrome, post-ICU syndrome, is actually it exists, but all our patients here do not actually require any active interventions per se that needs therapy for psychological therapy and things like that. So I will not be covering on those. So after the patients actually discharged from ICU and they are going to the general ward, we'll continue with gradual verticalization. So more often by this stage, patients' lungs will have recovered to the extent where they will be able to sit out of bed, and we'll do so as soon as they can. And we'll even start ambulation if the patient is able to tolerate. For the progressive interval exercise, we'll also continue to transit them to a more continuous mode of exercise training. So one thing for patients that are discharged from ICU is more often they don't have a respiratory tube in their mouth anymore. So they will be able to tell us how short of breath they actually are. So we will actually use the rate of perceived exertion scale. We are actually aiming for a 2 to 3 out of 10 on the modified Box scale for our patients during exercise. And this is to guide exercise intensity, and the aim is actually to increase exercise tolerability. So for some patients, due to the effects of COVID-19 virus on the lung itself, they may still require supplementary oxygen during rehabilitation, but they may not need it at rest, meaning that if they are actually resting in bed, the SpO2 is actually above 95, but the moment they start exercising, they will have desaturation, and it's due to exertional reasons. But we don't want these patients to also be on oxygen all the time, as we know that hypoxia may be harmful for some patients. So in this kind of scenario, we may need to provide oxygen therapy during exercise training to avoid hypoxemia and early onset of lactate acidosis, but we may not need to do that if the patient is just resting in bed the rest of the time. So the general guidelines that we have for SpO2 target is as follows. So for patients who are still hypoxemic, we will keep 94 to 96. For patients who are stable, anything from 90 to 94 during exercise training will be adequate. For patients with known respiratory disease such as COPD or other known risk factors for hypercapnic respiratory failure, then we will keep a lower range of about 88 to 92 as a SpO2 target during therapy itself. So for patients with COVID-19 infection, we also use outcome measures to actually assess this exertional desaturation, as we know that it can have a huge impact on aerobic exercise capacity. So for patients with COVID-19, they may have normal oxygen level at rest, but not during activities. And the point of doing this outcome measure is to then really exert this patient and to detect whether there's any significant exertional desaturation that needs intervention itself. So there are various modes of exercise testing, such as time walk test. I think a lot of you will be familiar with the 6-minute walk test. There's also things like step up test, sit to stand test, and step in place test. And each of these tests actually have their own limitations due to practicality issues because of space and time and equipment required. So as you can see on your right, this is a picture of one of the isolation room in NCID itself. It's actually quite small. So for us to do like a 6-minute walk test, that will not be possible. As such, we have to actually modify our outcome measures and choose the ones that are more practical for our use in a situation like this. So at NCID itself, we actually picked 2 of the tests. One of them is the 2-minute step in place test, as the patient needs to just step and lift up their knee to a specific height for a continuous period of 2 minutes, and we measure how many steps can take. There's also the 30-second sit to stand test, where the patients put their arms across their chest and they sit and stand for 30 seconds, and we measure how many repetitions they can do. For 6-minute walk tests, we only use them when the patient are de-isolated, where they are then allowed to walk outside of the isolation cubicle. Then there will be a pathway that is actually long enough for them to actually ambulate, and we can then assess their true exercise capacity. So this list is not exhaustive. We are not saying that we only use these outcome measures. If the patient is clinically indicated for further functional assessment, we would then use other outcome measures. But these are the ones that we actually look at when we consider patients for discharge and for COVID-19 itself. So what we do is we'll take the vitals such as blood pressure, heart rate, and SpO2 before and after the assessment. If the outcome measure will actually be terminated if patient develop any adverse symptoms such as severe breathlessness, chest pain, dizziness. So given the nature of COVID-19 itself, even a drop of 3% in SpO2 readings could be a cause for concern. And so for patients going home from our center itself, we look at SpO2 being more than 90% during exertion during the outcome measure assessment. So for example, if the patient's SpO2 was ambulating on the ward is above 92, but if they on the exercise testing they drop to say 88%, then we will also discuss with the team to decide whether this patient needs a temporary O2 service or should he stay for a little while until it resolves before discharging this patient home. So if the outcome measure actually indicates impaired exercise tolerance or a significant desaturation or exertion, or if patient is significantly breathless on exertion, we will then consider the need for either further rehabilitation or the need for oxygen therapy when they return to home. And this is all discussed in our multidisciplinary rehab rounds. So we will discuss all patients that had functional or rehabilitation needs. This is in order to facilitate weaning off of oxygen or to guide the provision of oxygen therapy during rehabilitation, as it may vary between physicians. So the aim of this round is to actually make sure everyone is practicing the same way. We will also be doing goal setting for patients. So for example, whether they are returning to work or what will be required of them at work, or even going home, are they still at a state where they can only ambulate short distances? Then do they need exercise therapy and training to get them to community ambulation again? As mentioned by Mr. Koh earlier, there are some effects of patients having nightmares, and even some memory difficulties. So this is also a way for us to signpost any of these special services if the patient do need it. So if they have significant memory issues, attention issues, or even like swallowing impairment, we would then signpost to the other allied health services accordingly. And one of the things that we do during this round is to also triage patients to different discharge destinations based on their rehabilitation needs, which I will be going through shortly. So now we'll be discussing about rehabilitation beyond the hospital setting. So in prospective cohort studies of SARS survivors, we already knew that there's persistent pulmonary function impairment in around a third of patients at 1-year follow-up. The health status of these SARS survivors is also significantly worse compared to healthy population. So that actually occurred around in 2004, SARS was around 2003. Early mobilization in ICU, we know that evidence started around 2009. So during that period, there was not a lot of pulmonary rehab, not a lot of early ICU mobilization. So we don't really know how these patients would have done if we were to do interventions as well. But based on our data that we know from COVID-19 survivors is that they also have impairment of diffusion capacity, with most common abnormality of lung function being diffusion capacity, and then followed by restrictive ventilatory defects, which both are associated with severity of the disease, which is why ICU patients may need actually a longer follow-up to actually see how it actually can affect their quality of life and even exercise tolerance. So given the diversity of presentation and rehabilitation needs, different patients will have different requirements for rehabilitation. And at the same time, some patients may require different services at different stages of their recovery. So this is something that we need to consider as clinicians. So for our center itself, post-discharge pulmonary outpatient consultation must be ready and prepared to allow adequate early assessment of this fatigue, anxiety, depression, even pulmonary function and exercise performance. This is actually recommended internationally for patients to be assessed after their discharge from the hospital. And there's also a suggestion from the International Task Force to consider routine follow-up for COVID-19 survivors when they are non-contagious to address any unmet rehabilitation needs for individual patients. So some of the considerations we have at our center would be things such as infection control status that will be according to your local hospital or institution policy, the duration of the rehabilitation they may require, the complexity of the care needs, whether they are on tracheostomy, whether they're still on NG feeding, do they need speech therapy review, and also other pulmonary rehabilitation or exercise training needs, such as are they having a lot of fatigue-related issues, significant breathlessness on exertion, significant desaturation on exertion, impact exercise tolerance, or even need for home modification if the patient is not back to functional baseline. So for our center itself, from the acute hospital, patients can be sent to a different sort of services. We have inpatient rehabilitation center, which would then see these patients for further inpatient functional rehab and pulmonary rehab to help them get back to their pre-morbid functional status. So I think in the news, we have heard that one of our Bangladeshi foreign migrant worker actually went and was discharged from rehab center. We also have community health team who is also on board with us to support our patients who are transiting to home. So this is a transitional service, and we know that during circuit breaker, a lot of the outpatient appointments were actually cancelled, and these community health team actually play a large role in supporting our patients who are then discharged during that period of time to make sure that when they return to home, there's no issues with their exercise tolerance and are able to then slowly transit back into the community with support from services like us, where there's doctors and rehab services to assist them if any of the needs do come through. And lastly, we have outpatient pulmonary rehab, which will then see this patient at the outpatient setting, where the patient would then come back for a follow-up assessment, like mentioned previously. So the difference in all this, just broadly speaking, will be things like inpatient rehab will be more for patients who still require assistance with mobility. They may require further functional rehabilitation and are not back to their functional baseline, and will really require specialized multidisciplinary rehabilitation, including weaning off of tracheostomy. So these group of patients we would then send to inpatient rehab center. So for community health team, we would then look at patients who may be homebound independent, but still have quite a number of issues, such as unable to go out into the community, unable to return to work, and still having quite significant breathlessness on exertion. So this service actually provides early community rehabilitation with integrated pulmonary rehabilitation to help these patients as much as possible to return to their pre-morbid function. And lastly, outpatient pulmonary rehab will be for patients who may be community ambulant, independent, may not require so much of specialized rehabilitation needs from a multidisciplinary team, but more for long-term rehabilitation for either decreased exercise tolerance, fatigue, or even some small degree of desaturation. So in conclusion, what I'm saying here is that patients who are critically ill with COVID-19 infection may present with cardiopulmonary impairment starting from the ICU, and this may actually persist beyond the ICU setting, just as what Mr. Koh has mentioned. Due to the variability in the clinical presentation of these patients, rehabilitation should be tailored according to individual needs. So for physicians and anyone who is on board to take care of these patients, to actually understand what these patients may actually need in terms of rehabilitation in a long-term sort of setting where they may have still exercise tolerance issue even after 6 months after discharge. Assessment of aerobic exercise capacity may be necessary to identify the presence of exertional desaturation and or impairments in exercise tolerance so that we know that there is such a problem, and we can then help a patient by putting them in a structured rehabilitation program to help them to get back to their pre-morbid status. Also considering the long-term impact of COVID-19 itself, especially in those who are severely ill from COVID-19. So patients should be discharged with follow-up services as appropriate as well. So with that, I would like to thank all the healthcare heroes at NCID itself, the Tan Tock Seng Hospital elite physiotherapy team who are looking after this group of patients, the physiotherapy department, and Dr. Jensen and Dr. Lee for giving me this opportunity to present. Thank you. These are my references.
Thank you, Audrey, for the great talk, as well as the very good work that you've done at NCID, taking care of a large proportion of our patients with COVID-19. With a question for you from the audience, could the new Apple Watch capability to measure oxygenation be useful for assessing exercise in post-COVID patients?
That is actually a very interesting question. I don't have the newest Apple Watch, but I guess it's something to think about. But we know that through different SpO2 oximeter device, they do differ between each other. You can buy the really cheap ones from say Taobao or Lazada, and then you also can get the very high quality ones that cost $100. So I guess it comes down to the accuracy of the SpO2 measurement, whether it really correlates with the true SpO2 level. I can't comment on whether Apple Watch capability matches that of a gold standard, but if say your patients on clinical assessment, they are not, it may be something useful for patients to monitor themselves if they were to go for exercises, to just know so that they know that they are safe, and to actually give them the confidence to do exercise that is guided by physicians but not supervised. Yeah, so maybe, could be, but someone probably have to look to a research about Apple Watches and other pulse oximeter.
Perhaps this could be your next project, to compare the efficacy of different types of smartwatches in terms of utility in monitoring saturations.
Yeah, definitely.
Maybe I could ask one question. So personally in my hospital, in the patients that we've encountered in the ICU and taken care of who've been intubated, we do notice that almost all of them actually do suffer some kind of residual dyspnea on exertion post-extubation in the immediate phase while they're with us in ICU or HID setting. So is this what you've encountered in NCIDs? Seeing that you all saw the bulk of the COVID patients there, and how long from your experience does this dyspnea on exertion actually last for?
Okay, so for dyspnea wise, there's actually a lot of patients who have dyspnea, even if they are not intubated or even didn't even go to ICU, they do have dyspnea. If we talk about specifically for ICU patients, as I mentioned earlier in the presentation, we have patients with dyspnea that is actually accompanied by peptinia autodeoxia, where we observe that the moment they're upright, they desaturate and they're actually symptomatic. So for this group of patients, they actually take a very long time to recover from that syndrome itself. Actually take up to weeks for it to actually resolve, and that's accompanied with dyspnea. So for our very first patient that we observed this in, when he came back for his follow-up about 6 months after, he was still quite breathless when we talked to him. And we really don't know how long it will actually then take for them to resolve. But the upside is, so with dyspnea, some patients actually do still achieve quite good exercise tolerance despite the dyspnea. And with exercise training, we know that it helps to decrease that sensation of dyspnea as well. It helps them to improve and feel less breathless. Regarding how long, I think we are still in the early stages because we have not sort of reached the 1-year mark for COVID-19 itself. We don't know what are the long-term effects that could have on these patients. We already are starting to see reports where CT is actually showing a lot of restrictive and diffusion defects. So they are sort of like an ILD patient where they may persistently still feel dyspnea long after the acute infection. So it's very, very hard to say. I would suggest that if these patients are coming back to your outpatient, do bring them for assessment, assess their exercise tolerance, and if necessary, to provide a rehabilitation such as pulmonary rehab to help them alleviate this dyspnea sensation that they may have.
Okay. One more question from the audience. How often would you suggest we check SpO2 levels for patients post-COVID?
SpO2 session for our center itself, we check all the way until they are discharged from the hospital. So for the outcome measures I've mentioned, we will usually do one the moment they wean off oxygen, and we will try and do one as close to discharge as possible to just make sure that they are actually okay and they don't have significant exertional desaturation. At our center, we actually use this mobile device known as the VZ Mobile, where they are continuously being monitored for the SpO2. So that was something that is used at our center. I understand it may not be possible for all centers, but if say in an outpatient setting, if you're assessing patient, I would think that if you're doing like a 6-minute walk test, you would want to measure the patient as per the protocol. And if it's inpatient setting for exercise training, particularly where we are exerting the patient, SpO2 monitoring will be quite important. Perhaps not when they are walking around. If we know they are not on exertion, they are fine, then these patients probably don't need further monitoring. But for those who have exertional desaturation, I would then recommend that they be monitored. Just, they can be desaturating walking around the room without knowing that they're desaturating.
Okay, I think this is the last of our questions. If there's no other questions from the audience, we'd like to thank everybody for your time with us in Track 5. We've hoped that we've provided some insight into, firstly, how our patients experiences through their COVID-19 infection, and also how we can improve nutrition and improve outcomes through nutrition as well as physiotherapy. Thank you, everybody, and then I will close the session at the moment. See you.